I have the distinct pleasure of introducing our next speaker, Dr. Jeannette Guarner. She's a professor of pathology at Emory University and very well known in the infectious pathology world. She's made significant contributions working at the CDC and now at Emory on different outbreaks ranging from Ebola, West Nile virus, SARS, you name it. On a personal note, I would like to take this opportunity to thank her because as I started my career and tried to pursue a career in pathology here in the States, we just happened to be both from Mexico. Through different acquaintances, she was the first point of contact for me coming here, and she's really made a significant impact, just pointing me in the right direction. So I'm delighted to present her, and the title of her talk is going to be Discovery of HIV virus as an etiologic agent of AIDS and how it was developed.
So since this is the history, well, first of all, thank you so much. I appreciate enormously the being here and being invited to this session. This is the history of pathology, so I thought it would be very pertinent to talk about the historical view of what pathology's role has been in the HIV pandemic. So we're going to start, let's see, okay, here. So here's the CME stuff. I have nothing to disclose. So I'm going to start from the very beginning. So in June of 1981, there's this MMWR publication. The MMWR is the publication that the CDC does on a weekly basis. And they describe 5 young men, homosexuals. That's the name that was given at the time. We didn't use MSM at that time. That had pneumocystis carinii pneumonia. Again, carinii not anymore. Girovechi. And 2 of the patients had died, and all 5 patients had also CMV. So the editorial suggested that there was a cellular immune dysfunction related to a common exposure. And they thought at the time that there was probably acquired through sexual contact. Obviously, the fact that they were MSMs. But how do we diagnose at the time pneumocystis? And as a matter of fact, up to very recently, how did we diagnose pneumocystis? It was the pathologist that diagnosed the pneumocystis. We didn't have a PCR or anything like that. We cannot culture this fungi, which at some point in time was a parasite. Now it's a fungus. So that's how we diagnose it. So then the next month, on July 1981, there's a second publication. In this publication, they describe 26 homosexual men that have Kaposi sarcoma. They also have 8 of these patients died. Then some of them also had pneumocystis carinii or Girovechi, and one had necrotizing toxoplasmosis in the CNS. And 12 of them also had CMV. Now, how at that time did we diagnose Kaposi? And I would say we continue to diagnose Kaposi by histopathology. Pneumocystis, we've already discussed how we diagnose it. CMV, again, how do we diagnose it? At that time, it was, in many instances, as a diagnosis of infection, not of having the presence of CMV. We diagnose it using biopsies, etc. So as everything that is done at CDC, there's an outbreak investigation, and there's the first thing that they do is they develop a case definition for surveillance. So the team that included a variety of different people basically decided that it had to be homosexual men, it had to be Kaposi or pneumocystis seen in the biopsy. So that was the case definition. And by the end of 81, we had 321 adult cases that included the pathologies, and some of them were children. There were 16 children, and 13 of the children were their mothers had been intravenous drug users. By 82, it was evident that many of the patients had had previous encounters or sexual encounters with others that had the same conditions. So obviously that was immediately, again, put into the sexually transmitted disease. This was, we knew at the time, the tip of the iceberg. We knew that we were going to see a lot more. So I have a question for you. What was the method that we used to diagnose patients with this syndrome? Because we're still talking about a syndrome. What was the method? Did we use flow cytometry, serology, manual CD4, CD8 counting, or molecular testing? 3, that's what we were using. We were doing manual testing for CD4, CD8. And as a matter of fact, this is how we did it. We took our blood, the blood from the patient. We got the Buffy code. The Buffy code was put in a cytospin. The cytospin was then stained with antibodies. And then we read the number of lymphocytes that had the staining or didn't have the staining. What is interesting to me, if we think about history, do you know when CDs, the clusters of differentiation, were first designed, or when we first started talking about cluster differentiation, CD? That was in 1982. All these cases were occurring in 81. And in 82, we started talking about CDs. So at this juncture, we were taking antibodies from different vendors, and we didn't even know what we were testing. We were testing probably for helper cells, suppressor cells, but we were not entirely sure. It was until the conference in Paris that everybody brought their different antibodies and decided how to name the different CDs. And so if you think about it, we're in the very early stages of even thinking about lymphomas and leukemias and obviously CD4, CD8 counting. So think about the timeline. 1981, we have pneumocystis, Kaposi, and these people were not taking any immunosuppressants. 1983, 1984, that's when we found out what the virus was. It took us 2 years, okay, maybe almost 3 years, to define what the causative agent of the disease was. And once we had the causative agent, then you could take the virus that was growing, you can lysate the cells where the virus is growing, and then create the first commercial tests that were used. So it was not until 1985 that we started being able to diagnose HIV. Okay, think about it. HIV was not, we already had a syndrome, but we did not have even a test. Okay, so why did it take so long? Well, we did not have at that time the way of culturing retroviruses. The molecular techniques were really totally in their infancy. And once we had an immunoassay, then the clinical laboratories could validate the test, but the test was very, very dirty because it had antigens from all sorts of different things if you use the ELISA. So we had to use something that could differentiate antibodies against different components of the cells where the viruses were being grown, or the virus itself. And that's where the Western blot was born. So we used that lysate was basically put into a gel, and then you had the different components of the virus, and then you could say, well, this is this virus or not. So it's interesting to think, why were we using this Western blot? The evolution of the test has been quite interesting in my point of view. We start with the first one with the virus lysate cells. Okay, obviously we were only testing for HIV-1, and it was only for IgG. In the second generation was in 87. We were testing for HIV-1 and HIV-2. Okay, we started using some recombinant tests or some recombinant proteins there, and then in 91, this is when the IgM, we could then detect IgM. This was a great accomplishment because the window period that could be about 30 to 40 days from when the patient got infected to when you could detect the antibodies being produced was quite reduced. And I'll show a slide later when that happens. And then the test that we're using currently is the fourth generation test, which came to the markets in Europe in 97. But what is fascinating to me is that that test did not come to the market and was not FDA approved till 13 years later in the United States. So we had to continue to use the Western blot, even though we already knew that this new fourth generation test was so much better because we could detect P24. We could detect the antigen itself, reducing the window period. So in the next slide, you can see the timeline for the different tests to become positive. You can see that nucleic acid detection is basically detected at 10 days after infection. The fourth generation test, whether it's a big instrument or we have some fourth generation tests that are done as rapid tests, and then it's a 2-week period. Then the third generation test, which was the IgM, not the P24, was longer, so on and so forth. But that's why nowadays we don't need to use the Western blot anymore. We don't need to do a confirmation of our test because our test is so much more robust, in addition to shortening so much the window period. The current algorithm basically starts with a fourth generation test. Then if you have a positive reaction, then you do a differentiation test so that you can decide whether it's an HIV-1 or an HIV-2 patient. There's different pathways for testing depending on the type, or whether it's HIV-1 or HIV-2. Now, if the test is indeterminate, then you do a molecular test, and then if the molecular test is negative, you don't have HIV. But if you have a positive molecular test, then you have HIV. But this is the current way of diagnosing HIV. Now I have a next question. What do we know regarding the beginning of HIV? Any takers? Okay, we needed to have a critical mass of people having the disease to be able to recognize it. Okay, if you think that that iceberg is exactly what needed to happen, we could not detect this with 1 or 2 cases. And here is the question that one asks: when can we find and when can we detect an outbreak when there's very few cases? Not like this, where there were so many cases already infected. So one of the interesting things when we talk about emerging infections is this very interesting publication that was done by Pike et al., where you can see that in the beginning of an epidemic or a virus or a bacteria coming to be a human pathogen, it basically circulates in animals, and then it starts going into humans, but it goes back and forth between animals and humans, but there's no human-to-human transmission. Once it gets into stage 4, then there's sustained human-to-human transmission. And then in the case of HIV, we're already in stage 5, when it's exclusive HIV, exclusive human-to-human transmission. So here's a recreation that I made up, in which you can see that SIV, the simian immune deficiency virus, mutated sometime in the 1920s or so, people believe. It was present in bushmeat and unsterile injections and sexual activity in Africa. And then that virus that had mutated then entered the human population and started being in the stage 4, stage 5. And then in the 1970s and in the early 80s, in Africa, there's an increase in cryptococcal meningitis, increasing wasting disease, increasing aggressive visceral Kaposi sarcoma, and diarrheal disease caused by cryptosporidium. From there, it goes into Europe, but it also goes into the Americas. For some unknown reason, well, we know the reason. We always want to say somebody else has it versus we have it. They decided it was in Haiti, but that's not necessarily what should or did happen. So one of the things where pathologists were very engaged is in Project SIDA. This was established in 1983. It was led by Jonathan Mann. That's the photograph at the top. And it was a collaboration between CDC, NIH, the Belgium Institute of Tropical Medicine, and the government of Zaire. And they were studying the laboratory clinical work and understanding what to do with the epidemic of HIV in Africa. And many people know Anne-Marie Nelson. She's one of the pathologists. She was the pathologist that was hired by Jonathan Mann to do the autopsies and to set up the labs over in Zaire. And she's been in the Infectious Disease Society for many, many, many years. So early in the pandemic, or now, when people have not received treatment, how do people present? They presented with a lot of opportunistic infections, but the opportunistic infections were extremely atypical. Instead of having to hunt for one TB bacillus, you can have tons of TB bacilli in the granulomas. You had Kaposi sarcoma in MSMs, but it was very infrequent in hemophiliacs. In Africa, the children died of pneumocystis, but adults did not have the infection. They had many other things. And there were multiple opportunistic infections at the same time. And now comes something that residents need to realize. This epidemics or these situations can be great opportunities. I was a young resident between 83, or a young person, I was a resident between 83 and 87. I took the opportunities as they came. I wrote a paper on cytologic detection of pneumocystis, tuberculosis manifestations in the patients with acquired immune deficiency syndrome. That's what published in JAMA. The primary non-Hodgkin's lymphoma of the heart was the first description of a primary lymphoma of the heart. And then we studied several patients with non-Hodgkin's lymphoma in patients with human immunodeficiency virus and looked for EBV in those patients. So the first treatment was AZT. This was a drug that was described in 1964, but it was sort of like an orphan drug, and it didn't get used until 1987, and its first approval was for HIV. The second antiretroviral, again, look at the timeline. 81, we discover what the virus is in 83, 84. 85, we have test. 87 is our first treatment. Super prolonged. Many people died in between. The second antiretroviral was the diadenosine, which was in 1991. In 1995, that's when we had HART, and then the drugs became generic. But a lot of the things that were happening were because of activism. There were a group called ACTS UP, AIDS Coalition to Unleash Power. I've never been in a conference or a USCAP conference or an ASCP meeting or anything like that. As I went to some of the meetings, the international HIV meetings, the color picture where you have Le Monde Tante, that occurred, and that's a photo from the Montreal meeting that occurred in 1989. And I can tell you, I was like shocked because these guys were with big drums going through the hallways, well, making all sorts of noise. They wanted to disrupt. They wanted to make sure that they got heard. They are people, they are all MSMs that were probably already infected, and they knew that things needed to change, that science needed to move, that the laboratory tests needed to go forward. Here you see them in front of Wall Street in the stock market, a boycott against Boros Welcome, so that they would release the different patents. So it was very interesting to work and see what ACT UP used to do. The other thing that was amazing during that period of time, and I think the quilt still exists, is the building of the quilt, where, especially being Mexican and having the Day of the Dead, something like this is so powerful, where you remember somebody because after they've died because of what they did in life and how they loved each other and all these things. And they created this humongous quilt for a lot of the people that had died of HIV, of AIDS, and it's pretty incredible that beautiful multiple quilts that are still kept, and they're absolutely fantastic. So we've obviously seen a lot of changes in pathology when patients adhere to treatment. Now the changes that we see in our patients that we're seeing is we see drug toxicity. We also see a lot of the iris, the immune reconstitution, inflammatory syndrome. We see a lot of syndromes due to perturbation of the immune system. They are mostly in the GI tract, in the neurological, in the CNS, but they're also seen in the GI tract. So it's interesting to think about the different changes that we see now when people adhere to the HIV medications. I'm going to represent real quickly a case. This is a 41-year-old woman that was diagnosed and treated for HIV for 16 years. She stopped because she could not afford the medications. She had been treated for toxoplasmosis. She had a headache and multiple brain lesions. She was started again on heart and Bactrim with little improvement. And then her viral load went from 27,000 to 700, which is incredible. The CD4 went up from 26 to 409. But here's the brain biopsy. You know, the lesions in the head were completely total inflammatory response to what? To the toxo that you see there. So you have the toxoplasmosis. This is definitely an iris, immune reconstitution syndrome, where the immune cells, when they come back, they basically try to kill whatever opportunistic infection there is in the tissues. Here you see the IHC4 toxo, and you also see the polyomavirus that the patient had. So I want to now talk a little bit about pathogenesis. We know that HIV comes in, but then it starts in the mucosas in the blood, and then it goes into the cellular reservoir. And you can see in the center the different the cells that are reservoirs for the HIV, and then in the reservoirs the virus can become latent and integrate into the genome. It can be persistent, or it can produce viral particles. And a lot of people in many places, particularly those centers that have primate centers, like Emory does, we're studying, or not we, the royal we from Emory, are studying the latency and how can we produce vaccines for HIV, and how can we also cure the disease if we can make all the reservoirs release the virus and then have the medication work in one bolus. Whether we're going to be able to cure the virus like that or not, we don't know. We'll find out. Now, what's the current status? The current status is researchers have lost their funding. Okay, the President's Emergency Plan for AIDS Relief, the PEPFAR, has disappeared. The PEPFAR was money that was sent to different countries in the world, and you could see the HIV and the deaths for HIV just plummeting in Africa and everywhere, but they had been disbanded. Okay, so all of a sudden, these countries are gonna, obviously it's a disease that kills little, in little stages. So we're going to start seeing again a surge on HIV. So we need advocacy. We need our new ACT UP. This is a call for people to think that we cannot stay how we are with no funding for our researchers, whether it's HIV or it's cancer, it's whatever. We need to continue having the funding, and we need to help the world. This is not a transaction. We need to help the world cure the disease. I'm putting the two AFIV fascicles here. The first fascicle on tropical diseases or infectious disease pathology was published in 1976. There's no mention of Kaposi. Well, they mentioned Kaposi, but not the aggressive kind. And there's no talk of HIV was not even known at then. They don't talk about wasting disease. The fascicle that I just wrote in 2024 with Thomas Lavick and Alejandro Vélez Hoyos, we obviously have a big chapter dedicated to HIV and obviously all other diseases surrounding this, the other opportunistic infections. I would like everybody to read this paper by Sebastian Lucas. He's one of the pathologists in the UK. He recently retired. And this paper that he wrote, and was a symposium that they were giving on HIV. And he writes a really beautiful paper. And at some point in time, he says, truly, in HIV/AIDS, we pathologists all around the world learned on the job by trial and error. And I don't disagree at all with that statement. This is a collection stamp of HIV or SIDA or AIDS postage stamps. As people know, I like postage stamps, so this is my collection of HIV. Thank you very much.
Thank you very much, Dr. Warner, for an amazing talk. And does anyone have any questions, please? Yeah.
I probably should know this, but what's the status, the current status of the term AIDS? Am I dating myself by using it, or is it still relevant?
So I think it's still relevant because it depicts a stage. Okay, so one thing is to be living with HIV, which there's a lot of people that live with HIV. However, when you go into AIDS, that's when you basically are sick, you have the opportunistic infection, so on and so forth. So it's still applicable. Okay, but we separate the people that, and listen to how I'm talking, people that live with HIV and people that have the disease.
But then if it's still used, is it a misnomer because it's not a syndrome anymore, it's a etiology-defined disease?
Well, I hear you, but let's dissect this a little bit. So when you have acute HIV, how does it present? Does it present, here I am, HIV? And really it doesn't. You know, it's a mononucleosis syndrome. Okay, you have a fever, you have a rash, you have lymph nodes, and then people test you for HIV. Okay, that's why now you're going to get me into a totally different tangent. Okay, the monospot test should be out the door because monospot doesn't test. It tests a syndrome. It tests heterophile antibodies against something that the person is producing, but it doesn't test for CMV or EBV or anything like that. So if you really want to know what a patient has with the syndrome of mononucleosis, then you have to do HIV, toxo, ABV, so on and so forth. So again, it's a syndrome, but it is used. Okay, I don't know if that makes sense. Yep. Mm-hmm. Okay.
Thank you so much, Dr. Guarner. My question is about the advocacy you mentioned as kind of a younger resident, upcoming, wanting to go into infectious disease. My question is, how do we kind of organize that? All the funding obviously has been just demolished recently, and it's very frustrating to see. And there are people dying from this, obviously, and we just have to kind of watch it. So I don't really understand, and you don't have to have the answer to this, but just what do we do? Because right now it's just, we can talk to our loved ones or colleagues and say, we hate what's going on. But, can we do something as an organization through CAP or through ASCP or something and say, we denounce this and we want funding reinstated? I'm kind of feel like I'm at a loss as to what to do.
Thank you for that question. I love it. So the ASCP does have an advocacy group. Okay, so they have an advocacy that goes to Congress. I don't know if USCAP does. I know that definitely ASCP, the American Society for Clinical Pathology, does. I know that CAP does. So we need to talk to our delegates. The next thing I'm going to say is, who usually votes in midterms? Okay, there's a few hands up there. Okay, who should vote this midterm? Everybody should be voting in this midterms. And that's something that we need to do. We need to stop what is happening by voting. And that's the only recourse I think we have. I think we definitely have, we're going to have to reconstruct an egg that has been broken. And that's going to be very difficult. Okay, but we have to try at least to do our civic duty. Definitely this year. Sorry for getting political.
Thank you. Thank you very much.